Okay, so I'm going to be talking about, I guess, a program of work that I've been working on for about the last decade, really, and I'm going to try and piece it together in half an hour. And it's mostly around the epidemiology and treatment of smoking and mental illness. These are my disclosures. So the work that I'll be talking about mostly today was supported by Cancer Research UK, currently funded by EPSRC and UKRI, and I also do consulting for public health bodies. And I was previously a scientific director in the pharmaceutical sector. So I worked there for 3 years. And that was unrelated to what I'm presenting today. So we'll be talking about two main bodies of work. The first one will be around the link between smoking cessation and mental health. And then the second one, I'll be talking about integrating smoking cessation treatments into psychological services. And I'll be presenting some data from some trials. And I always like to start this talk with a quote from a patient. And this was a patient I spoke to a few years ago as part of some PPI that I was doing in preparation for a project. And they told me that they were signed off of work with depression. They were asked if they smoked and they were encouraged to continue smoking. And they were given antidepressants in the same session. And that sounds quite shocking. A doctor telling someone, keep on smoking because if you stop, your mental health's at risk. So keep smoking and I'm going to give you some antidepressants. And this happens all the time. So for those of you who don't know, smoking rates are about 2 to 3 times higher in people with mental health problems. So in the gray, that's general population, pink and purple are people with anxiety and depression. And this leads to rough reduction in 20 years. And that's because of cardiovascular disease, cancer, all of the things that are they're related to poor health. And the population is motivated to stop smoking. But they often don't receive the support that they need. And a lot of the time they don't receive the support they need because of this common perception or myth that smoking somehow helps people to manage their stress, and it could actually be a form of self-medication. However, there's biologically plausible reasons why smoking may worsen mental health and why quitting may lead to mental health, including neuroadaptations, chronic inflammation, and it could actually be that stopping smoking could improve mental health. So to explore this hypothesis, I led on 2 systematic reviews that have been published over the last few years. One was published in British Medical Journal, and then we updated it as a Cochrane review. It's due for another update, but Cochrane reviews are a lot of work. So we'll see. They will have to pay me to do it. We will do it. And we published these reviews, and these were on the association between stopping smoking and mental health. And what we aimed to do was look at the difference in change in mental health between people who quit smoking and people who continued smoking. And we looked at mental health while they were all smokers, and then after they had their behavior change. So I won't go too much into methods in this talk because it's more about sort of the messages, and I've put QR codes throughout. So if there's something methodologically that you're interested in, I can talk to you about after, you can scan the codes. But in this review, we included longitudinal studies, trials that were analyzed by smoking status. And we did actually have one study where people were randomized to quit smoking and where people were randomized to continue smoking. So we included all populations, so we didn't have any restrictions on health status or country or whatever. And our exposure was stopping smoking, and the control group was continued smoking. And we looked at a variety of different outcomes, so anxiety, depression, stress, and social quality of life was another outcome that was actually chosen by our patient consultancy group. And for the meta-analysis, we pooled continuous outcomes. We also did another meta-analysis of incidence as well. So we pooled dichotomous outcomes. We used generic inverse variance random effects model. So essentially what that means is when studies report, if you've ever done a systematic review, Shine's in the middle of one right now, and everyone reports something very different, and generic inverse variance method allows you to pool raw data and also studies that report effect estimates, and you can combine them and slightly convert the data till you get to the point of a final effect estimate, and then you pool it. So again, we updated a previous review. So it was from inception, and the latest searches were updated in 2020. We translated all of our non-English studies, and we included as much missing data as possible. So if you know me, you know that I pester, and so I took that proactive approach and also pestered anyone who didn't report complete information in the reported studies to make sure that we had as much unpublished data as possible. So we screened over 20,000 studies, and we narrowed it down to a total included 102, and there were 13 ongoing studies. And then for a bit more context, so of the 100 studies, I think about 90 were included in the final meta-analysis, which included data from about 170,000 participants. So I'll present data from two outcomes. So this is depression, and this is a forest plot. Okay, so if the diamond here, which is the pooled effect estimate, falls on this side, it means that the effect favors the quitters, and if it falls on that side, that means that it favors the smokers. And then these are all of the different studies that reported depression outcomes. And what we found is that when people stopped smoking, that was associated with an improvement in mental health, or here a reduction in depression symptoms. And you can see our heterogeneity is quite high. I'll talk about that in a moment. And we found the exact same thing for anxiety. Again, a reduction in anxiety symptoms, or an improvement, mental health improvement. And I won't report all the other outcomes because they all showed the same thing. So social quality of life, mixed anxiety and depression. And then also when we pooled the incident effect estimates of incidents, I think we reported those odds ratios, they showed, again, the exact same thing. So stopping smoking was associated with improvements in mental health. But I guess the obvious question here, and I'm in the room where everyone's thinking this, probably even before I spoke, people are thinking, well, what's causing what? What is causing what? And that was one of the main questions in the review. And I'd like to point out that about, I think it was about a third of the studies included were actually meta-analyses, or sorry, were secondary analyses of randomized control trials. Let's see if this. Oh, yes. Okay. So what this means is that so in randomized control trials of smoking cessation interventions, everyone aims to quit at the beginning of the study. Okay. So if mental health improvement happened first, it would have happened here. It would have happened before baseline. It would have happened before they entered the trial. But what we found was that mental health improved here from baseline to follow-up. And also, when you look at randomized control trials, so we looked at trials, analyzed it by exposure. So whether or not people quit smoking or not, so you reanalyze the trial data by a different structure. But also, if you look at the trial data by the intervention group, so by, someone has nicotine replacement therapy or not, smoking cessation still improves in these trials. Okay. And then what we did was we did a subgroup analysis where we split the studies by whether it was a classic cohort study where reverse causality is a major risk. We had that study where people were randomized to keep smoking or to quit. I don't know how they got it through ethics, but they did. It was by Lynn Dawkins, one of my favorite studies because it's so unusual. And then also the secondary analyses of the randomized control trials. We did a subgroup analysis. What you can see is just off the bat, the effect estimates are all roughly the same direction, same precision. We didn't have any evidence for subgroup differences. So based on that argument, we concluded that reverse causality is quite unlikely. We also looked at a lot of the other, I guess, queries that you would look at in a systematic review of longitudinal evidence. So looking at the ascertainment of exposure and outcome and how strong those definitions were. So we looked at that data. We can this is a fraction of the sensitivity analyses that we did. There are probably 100, and I did this. I was actually I wrapped this up on December the 15th, and I gave birth to my son 5 days later. So I was like at my desk doing these sensitivity, and I was like, I've got to do this like any day now. And then he arrived 5 days later, and kindly my colleagues actually published this review. But there's about 100 sensitivity analyses that you can look at in the full Cochrane report. It's about 200 pages long if you're interested. So based on this review, so we have quite strong evidence that stopping smoking is associated with improved mental health across multiple outcomes, multiple study designs, multiple populations, multiple sensitivity tests. And at minimum, we can absolutely conclude that that mental health does not worsen as a result of stopping smoking, which is clinically what is important. And in addition, I wanted to sort of add this slide here that the evidence in this review is also supported by a variety of causal inference studies, many that I've been involved with in this group. So you recognize a lot of the names on these papers. So these are some MR studies that show that that smoking causes depression. And we further broke it down by, what are the constituents in tobacco that's causing this depression? Is it nicotine or the other stuff that's in tobacco? It looks like it's probably the other stuff. And then this was a study that used a different instrument that was in the CPRD, physicians' prescribing preferences. So we use physicians' prescribing preferences, and that's the proxy for the exposure, which is different stop smoking medicines. And again, we found the exact same thing after 5 years. That stopping smoking or prescribing stopping smoking medicines is actually associated with a reduction in antidepressants up to 5 years after a prescription. So again, we're seeing the exact same thing, that smoking causes mental health and stopping smoking improves mental health. And this really got me thinking, how are we going to translate this evidence? We've got these effect estimates. Clinicians typically, made some are more research heavy, might understand them, but not all of them will. So how are we going to translate this evidence? So we compared the effect estimates derived from our meta-analyses to effect estimates that were derived from randomized control trials of antidepressant treatment. And what we found is that the effect of stopping smoking is comparable to the effect of taking antidepressants. So we concluded that stopping smoking offers a benefit of that magnitude, the same as taking antidepressants. After doing a little bit more thinking about the meaning of that finding, and especially that translation, so if stopping smoking does benefit mental health to that large in that capacity, why isn't stopping smoking part of standard psychological treatment if we know that it helps people that much? Why isn't it just someone, they're going for depression, anxiety? Why isn't it one of the first things we're doing is helping them stop smoking to improve their health, to improve their mental health? So I was lucky enough to get Cancer Research UK trusted me with a lot of money to run 2 trials, and we did deliver, but we did 2 trials. So the first one, we integrated smoking cessation treatment into IAPT. I'll tell you a bit more about what that is, but psychology services, we did it face-to-face, and we also used their online platform. And I'll present those two trials in sum. So a little bit about the services we worked for. So these are, they're quite common services in the UK. So if any of you have had therapy in NHS, you probably attended one of these services. If you have friends that have attended NHS therapy, they probably attended one of these services. And they treat common mental illness, so depression, anxiety, OCD, and they receive over 1 million referrals each year. And half of those people receive evidence-based therapy, so like cognitive behavioral therapy. The first trial, so face-to-face trials, this is where the intervention's delivered face to face. So you're sitting in a room with a practitioner. So we delivered this across 4 English regions. Everything was pre-registered. We included adults with anxiety, depression. But what's important here, rather than listing all this off, it was a pragmatic trial. And what that means is we aim to match our patient population onto what IAPT sees normally. So if you're eligible for treatment in IAPT, that means you are eligible for our trial. So we didn't want to do anything weird and have lots of unusual cutoffs and reduce the generalizability of the trial findings. We included, if you're eligible for IAPT, you're eligible for our trial. Except for this pregnant, excluding people who are pregnant, that it was originally set, it was about 8 years ago, we set the exclusion criteria for this. We know a lot more now, and we know that pregnant people also need to quit smoking, and the stakes are potentially higher for that population. The treatment, so I'll go into a little bit more detail, but essentially, if you went in for an hour-long session with your therapist, 10 minutes of that would be focused on smoking and how smoking is related to mental health, and then also standard techniques about how to quit smoking and delivering smoking cessation medicines. And then the control group, that was standard IAPT care with delayed signposting to smoking cessation treatment. So the analysis, we did a very standard trial analysis. We did ITT, imputed missing data. For dichotomous outcomes, we used exact logistic regression models, continuous outcomes, linear regression models with adjustment for baseline values. And then we did do, because this was a pilot and feasibility study, the qualitative data were analyzed using thematic approach. So I'll tell you a little. Oh, did I tell you what the primary outcome was? Let me explain the primary outcome. So because this is an effectiveness trial. Okay, so this is the pilot and feasibility trial. So what that means is we're actually just looking to see if we can deliver the trial in these settings, if it's acceptable to patients, acceptable to staff. So our primary outcome was IAPT treatment completion status. So what that means is if you go into the service to have your depression treatment, if we offer you the smoking treatment and you don't like it, you then leave the service. If you do that, commissioners aren't going to commission the service because it's undermining the primary treatment goals, which is to go in for mental health treatment, right? So that was that was decided upon by commissioners. So we worked with commissioners to decide on that primary outcome. So the intervention. So this is a classic cognitive behavioral therapy model. So for those of you who aren't familiar with this, this is the model that psychologists use to help people explore how their thoughts, emotions, physical sensations, and behaviors are all linked. And this is the model within which we fit the smoking cycle and how it relates to mental health. And this was co-designed with clinicians and with patients. Essentially, this is an example. So this is an anxiety cycle where, say, that there's some sort of anxiety-provoking event, and the person might feel nervous or anxious, and they might feel a bit restless or tense, and they think, I need a cigarette, and I'll feel so much better after I have a cigarette. So they smoke. But then what we know about the half-life of nicotine and all the other constituents in tobacco is that they last about 20 minutes. And then the nicotine and all the other drugs wear off, and then you're back to the point again where you're at risk of feeling anxious and depressed because your body's not functioning, your brain's not functioning properly because it's not being maintained by the addictive substances. Okay, so this is the cycle that people are stuck in. The other thing, so you're not going to be able to read all that. Don't worry. It's just to show you that the therapist had a checklist. So we're very interested in part of my role as epidemiologist, but also as a behavioral scientist. We need to know what are the mechanisms of action. So what actually are we doing in each intervention session to help someone stop smoking? So we had a very precise checklist that the clinicians followed for each specific session, and this is what they followed. So everyone was trained in a very precise fashion. And we also had some psychoeducational videos about how smoking impacts on mental health. it does need to be updated based on more recent evidence, but this is what we used a few years ago. It plays. And some of you might recognize in that video, that was Anna Blackwell. So here are some of the qualitative work, and so I'm not a qualitative researcher, and I was not skeptical, but I didn't want to do it. But actually, as part of a trial, it was hugely useful, because when you're running a trial, so many things go wrong, and I did a trial so I could get a causal estimate, and actually, the amount of things that go wrong in a trial absolutely undermine the ability to get a causal estimate. So you have to keep talking to people to figure out what's going on. Are people delivering the intervention? Why are participants dropping out? Why aren't they signing up? How can we get people to attend follow-up? How can we do all these things? You have to talk to people to do that. And so we did lots of sort of reciprocal qualitative work and fixing things as we went along. We were also really interested in how people found the intervention. Is this something that would actually work in practice? So some of the therapists, because the therapists have to buy into it, right? If they don't buy into it, they're not going to deliver it. And what some of the therapists reported was that participants actually recovered on the anxiety and depression outcomes once they'd given up smoking. And then that enabled people to start breaking some of the other behaviors that were maintaining their depression. And other therapists said it's a really good idea to help people stop smoking when they're getting therapy, because we're already helping with their sleep, we're helping with their alcohol, we're helping them eat more vegetables, we're helping them go for a walk every day on top of their mental health, but you need to have all of these other things combined. So why aren't we working on smoking as well? So we had buy-in from the therapist, which was great. And these are just a few quotes, obviously. And then participants told us that what they really valued was having someone who could help them quit smoking alongside their mental health, because they felt that the two were so entwined, and to have someone break it down, that really, really benefited them and enabled them to stop smoking because of the confidence they had in their therapist. So this is our consort diagram. So I'll give you the top line stuff, don't read everything, so much detail. So we randomized 135 people, so we were powered for that primary outcome, which was whether or not people dropped out of the service. And we lost, I think it was about 33%, which is actually what I predicted we would lose, which is, I'm very proud of it, but it's unusually coincidental. And we analyzed everyone was included in the analysis at the end. So we used a variety of imputation. For anyone who's interested, we used worst case scenario and multivariable imputation compared to the effect estimates between the different imputation methods, and did all those types of things, which was very interesting. So these are the baseline characteristics. So again, what we're looking for here, we're looking for balance. The population, it was just over half female. They were quite unwell. So in terms of their depression, anxiety scores, those are quite high. And their smoking, it was like a medium level. So they're smoking about 14 cigarettes a day. They're not heavy smokers, which would be over 20, but they're smoking a lot. They're smoking about 1 cigarette every waking hour. And they're motivated to quit. So we had on average about 4 previous quit attempts. So these people had tried to stop smoking before. And these are some of the main outcomes at 3 months. So we did not find that offering the intervention caused people to leave the service, which is great, which is what we wanted. And you can see that we don't report p-values for any of our other outcomes because we're not powered to do so. But what we did find was that there was a higher quit rate in the treatment arm and more quit attempts in the treatment arm. And then we found that mental health was equal across the groups at the end. So in a larger trial, you would expect to see an improvement, and you do see improvements in larger trials. But imagine what you need to do to power that is you need enough people to quit smoking for the effect to show up in the actual number, right? And these results were replicated at 6 months as well. So so it was good news for the trial. So hopefully NIHR will fund me for a full one. So in a nutshell, so from the face-to-face intervention, what we found was that the trial procedures were acceptable and feasible. The intervention was accepted, and we also had evidence of intervention promise. So on to the next part of the story. So while I was running the first trial, I was also leading on another Cochrane review because I'm a glutton for punishment. And this one was internet-based interventions for smoking cessation. So this was of trials looking at internet interventions for quit smoking. And some of the results of the review, so top line, internet-based interventions work. They do help people quit smoking. You do have a lot of dropout from these trials, which can sometimes underestimate the effect estimate. But one thing I did notice was that there were no internet-based interventions for people with mental health problems, which, as we know, are the largest population of people who smoke. So I contacted a company called SilverCloud, and SilverCloud are the biggest provider of digital-based interventions to psychology services in the NHS. So how this works is the NHS buy a digital platform. They don't have their own. They don't have the resources to develop anything that is flash or works well enough. So they have commissioned a company to develop their internet-based platforms. So I contacted the company and I said, I've just led on the Cochrane review, and there's actually a gap in the market here. You don't have any interventions for people with mental health problems. I said, would you guys like to be involved in a grant I'm putting together? And they said yes, and we got it, which was fantastic news. And this was for another trial, and this was the digital platform now. So again, very similar intervention, stopping smoking in IAPT, in the psychology services, but it was part of their digital offering. That was the intervention. I don't think there's anything super special about it, but again, there was email information about the mental health benefits of quitting smoking and how to access the online program. And then treatment as usual was treatment as usual. There's nothing about smoking in there. And the outcome here was self-reported quit attempts. And so this was a bit of a funny stage because I got the funding for the trial, but then I went on maternity leave and kind of took a hiatus from academia. So it was a colleague, Anna Blackwell, who was running the trial, and I sort of oversaw things once a month. So the trial was kind of run with not very much involvement from me, which says a lot about how great Anna is. So we randomized 300 people, and again, so everyone says, oh, this is a really large feasibility study, but we have to account quite a lot of potential dropout. Also that, people might not access the smoking cessation one, because what would happen is they would be sort of ferried to see the anxiety depression programs, and then a smoking program would pop up and it was their choice whether or not they wanted to click on it. So it was very opportunistic. So we randomized 300 people. Very similar to the last trial, population they're quite unwell in terms of their depression, anxiety. Where's their data here? So we've got about just over half of them are about medium smokers. So again, in that sort of smoking just under a pack a day category. This is an example of one of the intervention pages. So if someone chose to engage with the smoking cessation program, this is what they would see. Again, this was co-designed with patients, and it was also based off of what we do in the UK as per standard, which is what we did in the last trials, that list I showed you. It was all that, but put into a really nice digestible platform. And we worked with SilverCloud, and they did all of the programming and coding to make this look really pretty. Because I absolutely wouldn't have been able to do that. So they and they also nested the randomization into their platform as well. And they've got all this set up now, which I'll talk to you about in a minute. So our feasibility outcomes, how did the trial go? So the trial team set up some what's called a stop criteria, which is commonly used in clinical trials. So we looked at, the number of people who were eligible, the number of people who viewed the program, number of quit attempts, and dropout and things like this. So what would we actually need to basically enough data? How much data do we have? And what would make sense to go forward into a larger trial? And do the numbers make sense for us to do that? And I'm still trying to figure out. So about 20% of eligible participants enrolled in the trial. That's what we expected based on the smoking prevalence rates that we see in the population. 20% of the people viewed the Stop Smoking program, which is good news. A little bit weird is that there was a similar number of quit attempts in the intervention and control arms. And I'm not quite sure why that is. And I still think about it almost every day. And we're going to do a bit more evaluation that I'll tell you about in a minute. And we did have a lot of missing data, and this is unexpected, or sorry, this is expected. So we know that 50% of participants in IAPT who engage with the with IAPT drop out by 6 months. And also in the Cochrane review that I did, about 30% of the studies had higher than 60% loss to follow-up. But the follow-up, it was done online, and then there were a lot of phone calls to try and reach people. And for whatever reason, we were unsuccessful, even though we paid people. So that kind of undermines some of the data collection, but I'll show you some of the top line results. So primary outcome was this, quit attempts, because that is a proxy for engagement, so whether or not people engage with the program. So even though there was a similar number of quit attempts, what it seems is that at 3 months, we had, so self-reported abstinence is the same, but biovalid, so when we actually get people to do a saliva sample to see if they have nicotine in their blood, there's some evidence, ITT in complete case, that we have a higher number of quits in the intervention arm, which is interesting. Again, not powered really to start looking at any of these outcomes. That's why p-values aren't reported. We're not seeing any evidence of harm or improvements in the psychological outcomes. I mean, the scores are slightly lower by. And then at 6 months, we see something else that's interesting. So we're seeing higher self-reported abstinence, but we're not able to biovalidate it. And I think that's probably coming down to, again, not able to chase people over the telephone, sending them out saliva packs and then not coming back. So in summary, this trial, so a good number of people viewed the program, which is good. There's some evidence that it helps people to quit, which is good. But we had high dropout, which undermines a lot of the conclusions. So what am I going to do next? So first thing is, so for the full trial of phase 1, we're applying for funding right now with HTA, and hopefully they like it. And I'm also working with the National Centre for Smoking Cessation and Training, which is our body in the UK, who they write all of the smoking cessation programs and then commission it. So I'm working with them to develop a package around this. And also I'm working with Silvercloud. This is really exciting. So I almost don't need to get funding for a full scale trial. I did surpass that stage, but I'm going to try and get a bit of funding because we do need a few extra resources to help. But Silvercloud have agreed to roll this out. So I've entered a commercialization agreement. We're going to roll it out, and we're going to have a continued evaluation of the program, which is fantastic. And they've already built the randomization into their software, which is also fantastic. So I'm really excited about that. So those are some of the translation steps. And I guess in summary, so we've got some pretty good evidence that people can be assured stopping smoking isn't going to worsen their mental health. It's very likely to improve their mental health. And I forgot to mention earlier, I've actually got a few PhD students at the moment, one who's just finished, and they've been looking at the mechanisms behind this. And one of my students, Catherine Sawyer, she's just done a huge meta-analysis looking at all the neuroscience data. So she's looked at, Shine, you might know this a bit better than me, but I won't ask you to, I'm sorry. But she's looked at all of the neuroimaging studies, looking at what happens when people smoke tobacco and what happens when people smoke cannabis, and what does this do to functionality of the brain, or sorry, the structure of the brain and all of the different parts in the brain. And actually what she's found is that people who smoke, there's a huge reduction in the total gray matter volume, the amygdala and the hippocampus. Those are related to memory and emotional regulation. Again, reverse causality. So she also looked at cannabis, what happens when people smoke cannabis, and we don't see any structural changes. So I don't know what that says. There's a lot that it could say, but that is indicating to me that tobacco is doing something to the brain that if you inhale something else is not happening to the brain. And then I've also another student of mine, Beza Kian, she's looking at she's doing mediation analysis, looking at inflammation. And what she's found is that the link between smoking tobacco and later mental health is mediated by inflammation. High sensitivity C-reactive proteins, so like a global marker of inflammation. So there are some. We're starting to understand a lot more about the biology behind this as well. So I think that's some people who worked with me. So thank you very much. There's my email if anyone has any questions. Thank you very much.
Thanks. That was awesome. I would just think, and this is like a bit peripheral to most of what's going on. But the thing about sort of what are the biological mechanisms responsible, separate to anything that might be happening, kind of, you know, that you pick up with brain scans. Smoking is really expensive and it's also really stigmatized. And two things that are bad for mental health is being poor and knowing that people think you're scum. So I wondered if, I mean, none of these things are mutually exclusive, right? Yeah. But I wondered if, like, I don't know, has anyone sort of taken a slightly more like sociological approach and looked at whether effects differ if you compare cultures where smoking is more versus less acceptable, or where taxes on cigarettes are higher versus lower?
Not that I know of, and I have thought about this stuff, and yeah, I mean, there are multiple mechanisms going on, you know, so we're damaging the body, we're damaging the brain, and we have neurotransmitter systems involved, damage there, but also there's a lot of psychology and social factors involved, and stigma is, I would guess it is, you know, if it would show you grant study, you would confirm that by policies, absolutely.
Because I guess, yeah, I was just thinking there would be a weird thing if, because obviously having really high taxes on cigarettes is supposed to stop people smoking, but it would be bad if where that didn't work, it increased people's depression, right? Not that what else it's about.
No, I mean it sounds like a great project to do. And I'm sure that you would find those mechanisms involved. Absolutely, you know, and it kind of, yeah, we'll go down the rabbit hole, but yeah, very interesting.
I was curious about sort of the digital intervention and trying to pick apart, like, does the digital intervention work versus your specific digital intervention? Because I think there can be a lot of things, especially like online. There's this thing called like A/B testing, where you have like different possible outcomes, and you sort of see it's kind of like an RCT, right? And then you see, you know, does A or B work better? And so I guess I'm curious how you pick apart your specific intervention versus do smoking cessation digital interventions in general work? Because it seemed like you were talking, you know, the reporting seemed to be a bit more about can this possibly work versus, you know, the specific literature that you have or anything like that. And I was curious how you can pick those apart.
So I guess to see if the actual intervention works, that's why we had the control arm, which was not a smoking intervention.
Sure.
So there's that part. But it's important because it's actually something we can evaluate in that.
Yeah, so I guess the difficulty is so you have like not using the resource versus using the resource, but then of course your resource can have different, you know, different literature, different ways of expressing it, different all those things. And so it can be a bit difficult to know, especially like you said, you had like high dropouts. It's like, was that due to the fact that, you know, trying to use a digital platform isn't
Yeah.
good, or is it because of your specific, you know, literature or resources?
Yeah,
It could be improved or doesn't express itself
yeah.
really well. And so I was curious if you have thought about like how you can untangle those, like that problem.
Yeah, so this is actually something the commercial partners picked up on, and they're like, this is why they want to continue evaluating it, because they want to tweak it.
Yeah.
And change different things to see if we can make it more engaging, because they picked up on the high dropout. I think high dropout, I mean, I wasn't there when I ran the trial, so, and I kind of wish that I was, because I was able to turn around dropout in my last trial. In quite a significant way. So I'm not quite sure what was going on, but the commercial partner, they're very interested in obviously keeping engagement up, because it increases the value of their product. And I'm obviously interested in improving the, you know, the public health, population health. And I think that, I guess what you're kind of talking about is like tweaking things and doing mini experiments within the trial based off of different expressions of the intervention. So we didn't do it and we're going to do it. So if you have any insights on how we can better do that, let me know. Absolutely.
There's a question on the chat.
Oh, is there? Oh.
Yeah.
Good improvement. Yeah, so we do find that people with higher depression are find it harder to quit smoking. But then when we've done sensitivity tests, thanks for the question. I don't know who AH is, but thank you. When Amy, thanks, Amy. But then when we did our Cochrane review and we compared people with quite severe mental health problems and depression compared to people who didn't have mental health problems, we actually found that there was a bigger improvement in mental health in those populations. So I think those people will find it harder to quit based on the evidence that we have to date. But when you do get them to quit, and again, this is this population we're working with in IAPT, they do experience a large improvement in mental health. And again, I guess you need to remember the population we worked with in IAPT were very unwell. And the quit rates that we see in this trial are actually slightly larger than what we'd see in other trials. So I don't know if I'm totally answering your question, but yes, they find it harder to quit. Improvement in mental health. I don't think so, because we're seeing the opposite. So the second part of the question, could improvement in mental health post-smoking cessation be explained by? I don't think so. We're seeing a larger improvement. And in our trial, we saw better quit rates as well. So I don't think so. If I've understood it correctly. So
Yeah, just a quick question about you. So your conclusions are that quitting smoking sometimes to improve mental health, which is great. But presumably there's sort of like is it like a refractory period or something? Like for the first 2 weeks, is mental health typically worse, or as they have those sort of withdrawal symptoms? I'm just interested in that really.
Yeah.
Over what period are we saying it's sort of going to get it's better?
So it's around 6 weeks is when withdrawal symptoms stop. And you see that in the brain, when that's when you see that the neurotransmitter systems start going back to normal or comparable to a non-smoker. So there are studies where you've got people who smoke, people who don't smoke. You get people to quit, scan their brains 6 weeks later, compare it to the never smoking group, and the scans of the brains are similar. People also report at 6 weeks, that's when they start feeling better. But then the actual improvement in mental health, so this doesn't seem to sort of dwindle over time. So we've looked at it over time, so up to 10 years. We've done analyses between studies that last, with 2-month follow-up, 6-month follow-up, 10 years follow-up, and we've compared them and there's no different. The effect size is the same over time, so it's relatively stable once you get past that 6-week period. Yeah.
Sorry.
Dave's first.
Yeah, I was just wondering, you mentioned with the review and meta-analysis you did right at the beginning. You mentioned you did some active chasing of the results that wasn't in the papers, and I wondered whether one of the sensitivity analyses that you mentioned was looking to see whether the results you got, the data you got by chasing, were in any way different from the data that were volunteered in
Yeah.
the paper.
So we looked at publication bias and small study bias, and we didn't find anything there. We also did, what's the test now? It's Egger's test. We did trim and fill. We did absolutely everything to examine publication bias, and we found no evidence.
So it's
So it's
missing more or less that sort of.
yeah, and a lot of the a lot of the studies, it was actually a secondary outcome. So it wasn't like, so if you think in a study, your primary outcome, that's what you report on, right? In your abstract, your title, that's what you're publishing about. A lot of the studies actually, the stuff about smoking and mental health was hidden in an appendix somewhere. So it wasn't the main finding. So it wasn't something that they thought was like headline grabbing, you see what I mean? So the motive to publish is slightly different.
So you're boosting your power by chasing, but not materially shaping bias.
So
Maybe look at relapse smokers and what the kind of what the association is there with either worse mental health outcomes and what sort of time frame you sort of classify them as having stopped smoking in. So where is the brain part?
So yes, we've looked at that. So it was one of my doctoral students. She just published a review where we basically looked at all these studies again and looked at people who had specifically relapsed and looked at their mental health. So when they relapse back to smoking, so their mental health doesn't worsen as a result of,
Okay.
isn't linked to relapse smoking isn't linked to worsening mental health. Their mental health kind of stays the same at the end. I imagine there's probably highs and lows that happen, but the end result, which is the follow-up, so that can be 6 months, say, after relapsing, their mental health is the same as what it was before, which is comparable to smokers.
Stopping smoking also can alter the availability of psychotropic drugs, right? Antidepressant, antipsychotics. I think most psychiatrists I know that would recommend keeping smoking. I don't think that's what everyone recommends. Would do it like in a situation where someone's put on antipsychotic, because if you then decide, you know what, I'm stopping today, you're just gonna nearly overdose yourself with some antipsychotics.
Yeah.
Are any of the studies stratified by whether people take medication or not? Because one supposed effect would be people that stop are actually higher in their antidepressant doses.
Yeah.
Right, because they're stopping and bioavailability goes up.
Yes, that was another sensitivity analysis that we did where we looked at people who were receiving either psychological interventions, so like talking therapy or medicine, and we didn't find that impacted the results.
Yeah.
And then one of the studies we did include was from Jensen. Vermeulen, is that how you say her last name? And it was one of her MR study.
Right.
Or was it? She sent me some data. It was for one of the reviews. I don't remember which one. And it was the same. The results aligned. But what you're saying about the antipsychotics. So smoking, yes, it metabolizes antipsychotics. So you have to take more antipsychotics while you're smoking. So when you quit, people are often there's a titration period of quitting. But the more antipsychotics that someone takes, it increases the risk of obesity, diabetes, which then can make you feel even worse, which makes you depressed. Yeah. So it's even more important in those populations that they quit. Yeah.
So I was just wondering, like, is there evidence in the reverse way that people who have reductions in, say, depression or anxiety scores smoke less after that? And maybe people going to wanting to quit smoking might be asked, do you have a common mental illness, perhaps? I mean, obviously, presumably smoking cessation is more intervenable than trying to treat mental illnesses, but I guess this is an interesting question.
So in the reviews, a lot of the studies, including from the general population, and some people quit as maybe as a result of an intervention. But a lot of the studies people quit, it was just a natural thing that happened in, say, a cohort study. And yes, their mental health improved. So you don't need to quit as part of a psychological intervention for your mental health to improve. A lot of the studies were of just, people like us, people in ALSPAC. I don't actually think we had any ALSPAC analyses in there. But we did have lots of cohort data, and it was general population, people whose mental health was improving as well.